Good afternoon. My name is Max Mokin, and it's an extreme pleasure to launch 2023 SVIN webinars. I promised last December that Parvaz Al-Mufti is going to take over as a chair of webinars, and Krishna Amuluri is a vice chair. But today we have a special, unique webinar. It is being supported by Imperative Care, and because Dr. Shahid Nimji and Dr. Fawaz Al-Mufti are super users, and they will be sharing their experience. Just for today's webinar, I'll assume the role of a moderator together with Krishna, but Krishna will be the lead. Again, a quick reminder is that Krishna and I will be monitoring the questions that the audience is going to ask through the chat option, so please use that if you have any questions for both speakers, because we'll not allow the audience to speak up otherwise. Krishna, would you like to add anything before we begin? And again, the reminder today is that we are talking about aspiration catheters technology and the influence of large bore catheters as they're becoming more and more common in our arsenal on stroke thrombectomy. And we'll have Fawaz sharing his experience first, and then Shahid Nimji will continue with his cases. So go ahead, Krishna, if you have any other questions or comments while Fawaz is taking over this presentation and uploading his
No, nothing to add on top of that, Max. Yeah, we're really excited to start this year of the webinar series. Hopefully we can, provide a lot of education to the users, to fellows, residents, medical students, etc. And we're all excited to see what Fawaz and Shahid have to say. Pretty casual. I think we're just going to go through some cases here from Fawaz and Shahid. Feel free to text in questions, and we'll try to get to all of them, or the most practically relevant ones. And as always, on a more of a casual side, and we hope this can be more of a discussion and a practical session to understand these catheters and how they are improve our therapies to large vessel and medium vessel occlusions.
Well, first of all, thank you guys so much for having us. I'm thrilled to be here. I think I don't know if I would refer to myself as a super user. I think super user implies superheroes, and I'm definitely not a superhero. I'm also not a super user, but like I've used these catheters and I like them. And I have like some tips and tricks that I'm hopefully going to be able to share with you guys that are not necessarily novel to many of you, but like I think for people considering a transition to aspiration, or like adding aspiration to their stroke armamentarium, stroke tools armamentarium, I think these hopefully will be beneficial. Sorry, can you guys see my slides? I'm not sure which one is sharing.
Yes, but as we're seeing it in like preview mode, so we can see the next slide as well. So if you hit display and swap, you should be good. Yeah.
Okay.
Perfect. That's full screen.
Terrific. Yeah. So I'm Fawaz Al-Mufti. I'm one of the neuroendovascular surgeons at Westchester Medical Center. I'm an interventional neurologist. I also do neurocritical care, and I'm the assistant dean for GME research at New York Medical College. These are my disclosures. I don't think I have anything relevant. I always jokingly say I have no conflicts, only interests. So aspiration catheters today, I would say, they've created almost a paradigm shift. So many of us started out with like stent retrievers only, but I'm sure like many, personally, I slowly but surely transitioned to aspiration as a first-line approach, with or without stent retrievers. And just to provide some historical perspective, before I go into like what the different catheters that we're going to talk today about are, when in 2005, we had the peripheral long sheets that were introduced, and they offered robust support unknowingly, they laid the groundwork for what was going to come next, which was essentially going to be balloon guide catheters that would allow us to achieve access and achieve some degree of flow control. Concomitantly, long sheaths, like around 2011, long sheaths with flexible tips were brought to the market. And while providing proximal support in 2022, the Zoom 88 is now a player in this realm, and now they offer this soft, flexible centimeters. And to the best of my knowledge, the Zoom 88 is the only 088 intracranial access catheter. Overall, I would say the Zoom 88 catheters offer this enhanced proximal support. They offer this continuous mid-shaft transition zones, and they also offer this distal flexible segment, almost 18.5 centimeters, with excellent trackability. And you have the Zoom 88. You also have the Zoom RDL, which is the radial access that recently came out. Additionally, I think it's really important to understand that these Zoom catheters also offer a wide array of vessel-matched aspiration catheters, and these angled or beveled TRX tips are designed for maximal clot ingestion. I was actually kind of interested to learn that based on bench work, they offer almost 15% greater clot engagement area compared to the flat tip catheters, and you can see this over here as well. Now, before we get into some of these cases, I wanted to talk a little bit about the technique, and this is very typical of the ADAPT technique. It's a little bit modified, in my opinion, for Zoom, because in this case, you're actually getting your guide catheter much higher than you're normally comfortable getting it up. So you usually have this high ascent. You position the Zoom 88 to begin with as high as you possibly can, typically in the distal cervical ICA, versus if possible, maximum in the cavernous ICA. That's the FDA on-label height. But then you slowly climb the system. You basically you deliver your Zoom aspiration catheter, and you bring the Zoom 88 higher. And ultimately, once you engage the clot, what I will typically do is I will try to get my Zoom 88 catheter as high as possible. We actually did a very brief poll of colleagues as far as if you're encountering a challenge, and again, this is an advanced talk for people who already do thrombectomies or fellows who've seen a lot of thrombectomies, but now are trying to think about what their practice is going to look like, or junior faculty or even senior faculty who've done a lot of these cases and are considering changes. So the questions we asked were, if you encounter a challenge with aspiration catheter trackability, meaning I'm trying to get the aspiration catheter and it keeps getting caught on the ophthalmic. So what's your immediate next step? And I'm happy to hear from Krishna, Max, and Shahid as far as what you guys typically do. Do you advance your guide catheter higher? Do you deploy a stent retriever, anchor, and try to advance that way? Do you use a different microcatheter? Do you do a larger microwire? Or do you completely use a different aspiration catheter? Just for the sake of conversation. Krishna, what do you typically do?
I think a lot of this depends on the level of the lesion. If it's a proximal large vessel occlusion, M1 carotid terminus, I'm typically, I'll give it a couple of tries advancing the aspiration catheter. But in general, I will just deploy a stent retriever and then use that as an anchor. And for the most part, that will enable me to get the aspiration catheter a little higher up. If it's a medium vessel occlusion, a little bit more distal, I don't think a lot of us are switching out to, different aspiration catheters off the bat. We try to, stick with what we have on the table or in the patient. In that sense, also, I think we'll give it a couple of tries, and then, with the smaller stent retrievers at 3 millimeters, also anchoring technique, and in those situations, try a little harder to recapture the entire stent retriever in the distal vessel.
Got it. What about you, Max?
No, I think Fawaz, you bring an excellent question, and this is something that we encounter almost in every stroke thrombectomy. I tend to look at the morphology of the the ophthalmic segment. And unless it's very challenging and there is just visually a good reason why the aspiration catheter is going to catch up on the takeoff of the ophthalmic, I usually try to track my guide higher. And often it will change the position of the aspiration catheter, perhaps displace it a little bit of the outer curve of the ophthalmic. I also tend to, quite frankly, I tend to use a second micro wire, whether it's the most cost-effective way of dealing with it or not. But I tend to have to add a second micro wire to the first one. But often trick A, manipulating the guide, bringing the guide higher into the say distal petrous or cavernous segment does the trick. And that was part of the reason why I started to use guides, highly trackable guides like the Zoom more and more often. Nimji.
Yeah, my experience is the same as Max's. I have found that, you know, I park my 088, my Zoom 0888 or the Trax 088, I park it in the cavernous every time. And I do it for the variety of reasons. One is to make, if I have to do a subsequent pass with an aspiration catheter, it's easier. And the second reason really speaks to Max's point, is it allows you to change the vector forces of your 027. I use an 027 over a 014 wire, and it just allows you to change the vector forces that it gets around that carotid siphon just fine and gets up into the intracranial space. And I mean, I've been fortunate as when I show you my slides, I haven't been, you know, I wasn't part of the Compass investigators. I wasn't an original ADAPT person, but in a very short period of time, it's revolutionized my practice, that every stroke I do is an aspiration first, because there's never a hindrance for me to get into the brain.
Yeah. So,
but can I interrupt you for a second, Fawaz? And I'll try to restrain myself from asking questions, but I want to go with this one. What I'm curious is, what was your perception initially when you were offered this new opportunity to try a much larger guide catheter that we typically would place so far up initially, if you still recall that? Were you hesitant? Were you reluctant?
I remember I was very scared. I was very scared. Like when I trained, guide catheter was barely in the carotid bulb. The intermediate was barely in the distal cervical. Like I was never like I had never seen this. But honestly, when I slowly got my hand on it, I obviously I like to play with these tools before I put them in the patient. I was actually pretty shocked at how flexible and and ultimately, once you got in, how trackable these are. So if I can confess, I was very apprehensive initially, but then I regained my confidence after a few cases.
Max,
all right, guys, we need to get to cases.
All right, sounds good. So 45% had advanced guide, said that they would advance their catheter. Another 45% said they did deploy a stent retriever. So I just want to show you guys how, like the point that Max just pointed out. So look at what happens if this is a Zoom 71, it's getting caught on the ophthalmic. If you advance your guide, you change the vector sufficiently so that you can actually traverse the Zoom 7, traverse across the ophthalmic much more easily. I'm going to show you this one case. This was an 84-year-old man who presented with a dense left MCA syndrome, NIH score was 26, was last known well hours prior, and was given TPA. He was intubated in the ER for airway protection given severe neurologic deficits. His CT was negative for hemorrhage, but had a favorable aspect, largely preserved aspect, with a small hyperdensity in the anterior temporal region. CTA revealed a left M1 occlusion just distal to the origin of the left anterior temporal artery. This is basically what we found on the initial run. Now, I really want to show you guys this. So this is the ophthalmic, the Zoom 71 getting caught on the ophthalmic. And here, my fellow is getting very excited with the microwire traversing into the PCOM, as you can see. And you can see I could not get it. I mean, we tried very hard. Look at what happened when I actually positioned the Zoom 88 much higher. All right. look at how it traversed it very, very nicely. It just changes the vector sufficiently. And now we were able to get into the M1. And ultimately, I was even able to get the Zoom 88 much higher as well. All right, I'm sorry, the sound is deafening. Sorry. And here we were able to achieve TICI3 recanalization. I was very happy with the result. This is the clot that we pulled out. And this is the first case that, like, one of the earlier cases where I was like, I didn't even know that this is what was going to happen. But I really felt that, like, if I gave the, now that I have a guide catheter that I can actually safely get higher up, I was able to actually more reliably be able to get my aspiration catheter into M1. So another question, just to stir conversation. How important is flow control to some of you guys? Very important, fairly important, important, or not important at all? Krishna.
And are you referring here to the role of balloon
Like
guide
arrest.
catheters?
Like a balloon guide
Flow arrest.
catheter, or like flow arrest in general?
What do you think, Krishna?
I think, you know, I've had a couple of partners at SVIN, and I think balloon guide catheters have fallen off the map a little bit in the last several years. But I think that the current thought is that, you know, flow control proximally is becoming a more undervalued entity, and not only in strokes, but also carotid stenting. So, you know, I would probably say B or C. My answer, fairly important to important. You know, again, we're all a product of our training. We didn't really train that much with balloon guide catheters in my training. We feel that, you know, you can get proximal flow control if you get the guide catheter up distally into the distal cervical, and something with like the Zoom 88, if you're actually able to get it into the proximal cavernous, then, you know, you have a greater chance of achieving flow control proximally. How about you, Max?
I think I'm with you on this one. And I mean, we have to admit, I would say that the data in support of balloon guides is pretty strong, albeit it's all sort of retrospective. I wish we had a prospective trial, but I tend to ignore that a little bit just because I like the ease of using these catheters and how far they go and how you could arrest the tapering vessels probably just effectively. Once you bring it to the cavernous supraclinoid, there's not much flow around in most of the cases. But, you know, who knows, if there might be some extra advantage to having a balloon guide, but it comes with a certain degree of cost, time, manipulation.
As a segue, Fawaz, do you one of the questions from one of the attendees was, you know, it's hard to always put numbers on this, but the question is, how often does the Zoom 88 reach the M1 for you? Is it, you know, around 40% or greater than 40%? Anecdotally,
I think that's an excellent question. I would say, in my hands, I would say, and again, I'm not super skilled in any way, shape, or form, but I feel like it's around 60% I can get the Zoom 88. But honestly, even if I can't get it as high as I want to, sometimes the anatomy is just not favorable. The higher, we know that the higher you can get your Zoom 88, the higher you get the guide catheter, the more flow arrest that you can achieve. So, I mean, in my mind, the classic limitation of aspiration catheters has been that when they actually grab the clot, they're actually grabbing the head of the clot, right? So with fibril, red blood cell, RBC-rich clots, they can break at the tail. So you can leave clots there, and you can very well end up with like emboli to new territory. So in my mind, like achieving flow control will allow us to achieve better aspiration power and ultimately better like clot retrieval. So this is primarily due to the fact that I guess we oversee or overlook sometimes, and I know I think Dr. Raul Noguera talks about that quite a lot, is that you don't really have flow control like all the time with an aspiration catheter in the M1 because there's this huge discrepancy. Despite our best effort, there's a discrepancy between the size of the aspiration catheter and the cross-sectional area of the vessel. And the larger the aspiration catheter, the better the aspiration power. If you go from an 068 to an 072, that's almost 10% more aspiration power. If you go from an 068 to an 074, that's almost 20% more aspiration power. So as far as like this question is concerned, a good number of people said it's like fairly important or very important that you have some degree of flow arrest in order to get optimal aspiration power. So this is a nice animation where you can see as the zoom 80 is going higher, there's a significant reduction in flow, and the larger aspiration catheters offer better flow control with improved aspiration power, with higher suction force and an ability to completely ingest the clot, and leading to a higher likelihood of here, let me see if I can play this again, a higher likelihood of recanalization. So balloon guide catheters typically stop antegrade flow, but you can continue to have flow through the ACOM and the PCOM. Hence, there's always a risk of like emboli to new territories. It's never perfect. And although this is like that, what I'm showing you here is just an animation, I've definitely seen stagnation distal or downstream to where my Zoom 88 is when it's positioned higher up. And the higher I get it, the more likely I am to achieve flow arrest or to slow the flow and optimize recanalization. So this is another case of a 37-year-old pregnant female with COVID, factor V Leiden, not on anticoagulation, presents with acute aphasia, hemiplegia, and an NIH scale of 14. She was last known well almost 16 hours prior. Her CT head was negative for hemorrhage, and her aspect score was largely preserved. A CT perfusion showed a huge penumbra. Thrombolysis was not offered since she was out of the window, but CTA demonstrated an M1 occlusion. And again, here there's a distal left M1 occlusion, and you can see it over here, a large area that's being starved. And over here, you can see me climbing the system and positioning the Zoom 88 intracranially. And I found that this actually portends, and you can see over here, I don't know if you can see my cursor, but this is the Zoom 88. I'm getting it into M1, and it definitely portends a better flow arrest and recanalization.
Fawaz, I have a quick technical question for you. So I noticed that you crossed the occlusion with your guide wire and the microcatheter. Is that something you try to do
No, actually,
most of the time?
No, that's a good observation. I actually try never to cross my clot. If I can avoid crossing the clot, I always try to avoid it. And I tried very, very hard, but I couldn't, I felt like I needed more purchase. So in this one case, I actually got everything more distal, got an 027 microcatheter more distal, got the Zoom 71 and followed it with a Zoom 88. And once you get close to the M1, the proximal M1, you get actually excellent flow control at that point. And there was like TK3 recanalization. This is one of the clots. We got a good amount of clots here. And this patient was discharged within 7 days with a modified Rankin score of 1. She ultimately delivered twins. She named one of them Fawaz. No, I'm just joking.
Fawaz, one question, what micro wire did you use in that case?
I was a Synchro 2 standard.
Got it.
I'm gonna show my last case, which was a 50-year-old female with recurrent posterior circulation stroke. So this patient has been having like stroke after stroke and leaving AMA. Her last stroke was almost 2 weeks prior. She received thrombolysis, but already came to me with established non-debilitating subacute brainstem infarct in the pons in the midbrain and bilateral PCA territories. Excuse a typo here. The patient presented with acute dysarthria and visual disturbances, unexplained by her existing stroke, and her NIH score was like 8. If you exclude the existing deficits. Non-invasive vascular imaging was concerning for basilar artery occlusion. Given these findings, the patient was deemed a suitable candidate for mechanical thrombectomy. This was my setup. I used the Velocity 027, Synchro 014, a glide wire, and ultimately I did this actually a Zoom 35. Sorry, I also used a Zoom 71. So Her left vert was actually occluded at the origin. The right, the radial artery, I decided I was going to go radial in this case. I typically don't go radial for all of my strokes, but if it's a posterior circulation, relatively young patient, I thought it was going to be a straightforward, an easy shot. What I didn't realize is she is relatively young. The origin of the radial artery was relatively high. So she went into some spasm, but I wasn't able to, although I had a 6'7" slender, I wasn't able to get my an 088 catheter through that, where I didn't feel comfortable. So I ended up using an 071, a Zoom 71. I used that as my guide. I probably shouldn't have used it as my guide, but I did, and it worked really well. And you can see over here, this is the M1 occlusion. This case may be familiar to some of you because I've shared this on because I needed some advice here. And you can see, although there is a clot here, what is really interesting is she also had another clot, like literally over here. Apologize, I don't have a video, but that clot was literally dancing in that area. Like it was literally floating in that territory. A single pass aspiration resulted in basilar, recanalized it. You can see over here, there is a right P1 occlusion, but because she had a well-established large PCA territory infarct on the right, I chose not to chase that because I was like, I mean, I'm opening up a blood vessel that's supplying dead tissue anyway, so I didn't choose it. It was relatively, I could have easily chased it, but I chose not to. Now, you can see over here, that's a clot that's still there. And I was genuinely concerned that this will ultimately dislodge again. I deferred endovascular thrombectomy for that non-flow limiting thrombus. And I think ultimately I sought the expertise of some colleagues, and I think most people said that they would probably do the same thing. And again, I'm curious to hear your thoughts, whether you guys would have chased this or not, but I didn't really have an easy approach to an easy way to change this. And ultimately I chose to put this patient on anticoagulation.
So what I did, it's funny you mentioned that, Fuad. Could you go back to that previous?
Yeah.
So I had a very similar case like yours in the posterior circulation. And I went up the left wrist because that's what it looked like is the most advantageous on the CTA. And I, like you, I actually just used the Zoom 71 to get there. And I ran into this clot before my top of the basilar occlusion. And so what I ended up doing is I just treated it like a whole vacuum cleaner. And so I sucked out the first clot, got me to, did my first pass, and, clot came into the clot pod. Then did my second pass with, I think I couldn't do a 71 at that point because the basilar got too small. And so then I just used, I think, a Zoom 45 and took out the second clot. And it just speaks, I think what you did was right. It looks like you came from the right and took out the clot. And so you left the left. And I think that's wholly appropriate. I just ended up having a scenario where I looked angiographically very similar to you, but I went up the left. And so the idea of using an aspiration catheter to suck out a mobile clot is certainly not a problem. And I would tell the users that if you're going up the ipsilateral side of your proximal, mobile thrombus and where your terminal occlusive thrombus is, take them both out. And it's fine. And your worst case scenario, it just adds to the thrombus load at the top, which you're going after anyway. So take it out. Yeah. So in this case, the left vert origin was actually occluded. So we could not. Well, there you go. There's your answer. I would have to basically have to go up and down the VB junction, down that side. And I thought it was just a bit too much. Totally. And your flow is going the other way then, right? You're likely, if that's the case, if you're actually having flow that's going to drive it towards the neck and not up into the head. So you may totally, why would you take it out? Exactly.
But was a couple of technical questions from the audience here. You showed a couple of cases where you were able to track that 08, the Zoom 88 into the M1. How often over the 71? How often are you aspirating directly from the 088 itself?
So if it's an M1 occlusion, I'll actually take the 71 out, and I'm like, I have my 088 at the face of the clot.
Sure.
I'll actually take my 71 and aspirate with that. If it's an M2 occlusion, I will keep my 071, my Zoom 71 where it needs to be, and keep and use the Zoom 88 for flow arrest more than anything.
Got it.
This is the clot. So basically, she actually improved. I did this awake, and she improved right away. So I chose to abort. I wasn't happy with myself. I thought it was a bit of a chicken move, but in hindsight, I think it was the right thing for the patient. She continued to do well. So I just want to talk about very briefly, just lay some literature here before I hand the floor over to the podium over to Dr. Nimji. But in this one study, a single center study, so not large, at Ushering Medical Center, they used these, they sought to evaluate the benefits of intracranial guide catheter placement for aspiration. This was a single center retrospective study, 92 patients treated with aspiration first approach from 2020 to 2022. Patients were allocated into two groups, the control group and the intracranial group. The control group where the distal tip was positioned in the cervical ICA, and the distal tip where the tip of the catheter was deployed in the petrous or even further distal. What they found was, like you can see in here, the intracranial group versus the control group, there was really nothing that was statistically significant between the two groups. But what they found that there was slightly better final reperfusion, final TK2C recanalization. There was better TK2C, first pass TK2C effect was almost 50% versus 28%. Time from access to final reperfusion was shorter. And this was all statistically significant. And the incidence of hemorrhagic transformation, intracranial hemorrhage, I thought was interesting, was almost 0%. So in conclusion, granted, you got to take this with a grain of salt. This is a single center study, a good number of patients. But I think overall, I felt like this was a representative sample of like the overall number of cases. And I think Dr. Nimji is going to show his cases and his excellent results as well. But basically, intracranial guide catheter position was associated with better final reperfusion rates, better first pass effect, and quicker reperfusion times in patients suffering from large vessel occlusion strokes. Yeah, with that, I will hand the floor over to Dr. Nimji.